We are going to begin with the medical coding guidelines 60,000 series. One of the student has requested. This is a nervous system which we are going to divide into four parts, and we'll begin with the part one. So in the 60,000 series, in the beginning, we are going to cover few glands which are endocrine gland, but they are the part of the 60,000 series. So the first is the thyroid gland. It is a butterfly-shaped gland located in the front of the neck beneath the voice box, which is responsible for producing the thyroid hormone that regulates metabolism, growth, and the development. So one must know the structure of the gland. So the thyroid gland comprises of the two main parts, that is the two lobes and then the isthmus which connects them. The two lobes, one on each side of the neck, are connected by the isthmus. So this is the connecting bridge which is called as isthmus. It sits in front of the trachea. The thyroid gland produces two important hormones. One is T4, which is called as a thyroxine, and triiodothyronine, which is essential for regulating the metabolism, growth, and the development, and are produced by the thyroid gland. They control many bodily functions by influencing the heart rate, body temperature, and even the mood. The posterior part of the thyroid gland, where you can see the four dot-like structure, they are nothing but the parathyroid gland. So one must know the location of the parathyroid gland also. Now the thyroid gland codes, they range from 60,000 to 60,300, and it mainly consists of the various procedures that we carried out on the thyroid gland. Now depending upon the structure that we take out, we call it as a lobectomy, partial lobectomy, bilobectomy. And if you see what is a thyroidectomy, it is nothing but a broader term for the surgical removal of the thyroid gland. Because ectomy is removal and thyroid is a thyroid gland. It can be total or partial. Now the total thyroidectomy is the removal of the entire thyroid gland. While the partial thyroidectomy is removal of the only part of the thyroid gland. This can include removing the single lobe, which is called as a lobectomy, or the part of that lobe which is called as a hemithyroidectomy, or the isthmus, the bridge between the two lobes. That is called as a partial thyroidectomy. And lobectomy, this specifically refers to the removal of the one thyroid lobe, that is one of the gland. It is a type of the partial thyroidectomy. So pay attention what has been removed, because that will define your code. So if you see the code language, you will see that they have written the partial thyroid lobectomy, and everywhere it is either the unilateral with or without isthmectomy. So pay attention to the language of the code, whether you have carried out unilateral or bilateral. Contralateral means both the side. Here I have taken the example of the tie bow, and with the help of that diagram I tried to explain what do you mean by partial thyroid lobectomy. So partial means part of the lobe has been removed, and it can be unilateral. Then contralateral subtotal lobectomy, it looks somewhat like this. Contralateral means both the side. Then the total thyroid lobectomy means one lobe has been completely removed. So this particular diagrammatic representation will give you idea that what has been removed into the thyroid. Most of the time we remove the thyroid whenever we are suspecting any malignancy. So pay attention to all those important terminology. And then of course the approach is also another consideration when we are selecting the code, like the transthoracic approach here. Okay. So beside thyroid gland, there are some other glands which we are going to cover in this 60,000. One is parathyroid gland. So if you see the parathyroid gland, the location is near the thyroid gland in the neck. Typically, there are four in number. And if you see this particular diagram, you will understand. It is at the back side of the thyroid, you will see these four glands. Now the function is to regulate the calcium and phosphorus level in the blood and the bones. Hormone produces by the parathyroid gland, which is the parathyroid hormone. It helps to maintain the calcium balance. Then we have a thymus gland located in the upper part of the chest, just behind the sternum. The function, it plays a crucial role in the immune system by producing the white blood cells that fight the infection and destroy the abnormal cell. Hormone secreted by the thymus gland is thymosin, which is involved in the development of the T cells. An adrenal gland, which is located at the top of each kidney. So there are two adrenal glands. The function involves the stress response, the blood pressure regulation, and other metabolic function. And hormones, it produces the hormone like epinephrine and aldosterone and cortisol. Epinephrine increases the blood pressure and heart rate. Aldosterone controls the salt and water balance, and cortisol plays role in stress response. So I have covered the gland with some important pointers about the hormone and the function, because that's a part of your anatomy syllabus. So the mainly what we are going to see in this chapter is the various surgical procedure that are carried out on this particular organ, and they are mainly removal of the this gland. If the removal of the parathyroid gland is called as a parathyroidectomy, and that of adrenal gland is called as a adrenalectomy, and thymus gland is called as a thymectomy. So you will see that you have this one particular medical terminology that will help you to zero down the code. And uh, similarly, you will see that they sometime we do use the laparoscopic procedure or the laparoscopic way to remove the gland. So one must know that how the gland has been removed. Like here, if you see the code 60650, it talks about the laparoscopic surgical removal of the adrenal gland. And remember, this is a general coding guideline, that if the surgical laparoscopy is done and the diagnostic laparoscopy is done in the same session on the same side, then we code only for the surgical. This particular guideline applies to all the laparoscopic procedure that are carried out in the human body. And so pay attention what has been removed, and depending upon that, we can pick up the code. Now let us take some examples or the question that will strengthen your guideline. Remember, the only way to pass the CPC exam is to practice a lot of questions. And the question they ask in the exam, they are very intelligent. So you have to be extremely careful in reading them properly. The physician performs the right thyroid lobectomy. The patient was prep-draped. After adequate general anesthesia, the neck was incised on the right side and sharp dissection was then used to cut down onto the strap muscle, sternocleidomastoid mustard muscle. The strap muscles were separated, transected on the right side. A small thyroid lobe was visualized and dissected. There was no evidence of tumor. The wound was closed with 3.0 interrupted vicryl for the platysma and 4.0 vicryl for the deep tissue and 6.0 fast absorbing gut for the skin. Code the encounter. So what they have done is the physician performs the right thyroid lobectomy. So they have removed the part of the right thyroid lobe, and we need to code for that. And now you remember that from the anatomical designing of the gland, we know that there is a right and a left lobe. So pay attention that what has been removed, and depending upon that, we are going to code it. So if you see all this code, the code talks about the various part that has been removed. Somewhere it is only the lobectomy, somewhere it is lobectomy with isthmectomy, and somewhere it is the total removal of the thyroid gland. Now in this patient, it is the lobectomy that has happened. So tell me what is the answer. So yes, the answer is 60220, because if you see the code 60210, it also talks about the lobectomy, but it is a partial thyroid lobectomy, and in our case, they removed the right lobe completely. So 60220, which is a total thyroid lobectomy, unilateral, with or without hysterectomy. So we will go with the code 60220, and right is we will write which side you have removed. Let us take the next question. Jennifer was admitted to the hospital for an aspiration of the two thyroid cysts. Her physician completed this procedure with a CT guidance of the needle, including the interpretation and report. How would you report the professional service? Now, in this case, what has happened is, if you have seen the options, everywhere there is a code 60300. So we need to read the parenthetical notes in order to pick up the correct answer. So aspiration of the and or injection of the thyroid cyst. In our case, how many cysts? Two cysts. So this talks about only one cyst. And if it is a two cyst, we will definitely require 60300 twice. Okay. So let us see what's the answer, or you can help me zero down the answer. So if you see 60300, it is written only once. We have two thyroid cysts, so we cannot take the option D. C is 10021, which is talking about the fine needle aspiration. And if you remember, that is a code for the non-imaging technique. First of all, whenever it is a FNA, they will clearly write it is a needle, but they haven't written it as a fine needle. So that is one important thing. And then if you see the code 6030026 and 76942, 76942 is a ultrasound guidance. In our case, it is a CT guidance. And 26 modifier, we always put it on the radiological code, because the interpretation and report interpretation of that CT has been happened by the doctor, so we will require that. So B is the correct answer. Two cysts, so we will write it two, because this doesn't say thyroid cysts. I mean, there is no plural, it is only one. The provider removes the thymus gland in 27-year-old female with myasthenia gravis using the transcervical approach. The blood supply to the thymus is divided and the thymus is dissected free from the pericardium and the thymus is removed. What CPT code is reported for the procedure? What has happened here is removal of the thymus gland, and which is called as a thymectomy. Now, if you see the code, there is a code 60520 520 is a thymectomy, partial or total. And what is the approach? In our case, the approach is transcervical approach. Here it is a transthoracic approach. This is a sternal split or transthoracic approach with radical mediastinal dissection. So, pay attention what has been done with the patient, and then we need to answer the question. And 60540 is a removal of the adrenal gland, not the thymus. So definitely D we will eliminate, because it is the gland itself is not correct. In between these three, tell me what is the answer. So yes, A is the correct answer, because all these three talks about the thymectomy. But if you see the 60520, it talks about the approach. How did you approach that gland? And transcervical is the approach which the doctor has taken. So 60520 is the correct answer. So remember, always do more practice. You will start reading all this minor detail, and then you will never go wrong. Now the next question, the patient with primary hyperparathyroidism undergoes parathyroid nuclear medicine scan and ultrasound and is found to have only one disease, parathyroid. A minimally invasive parathyroidectomy is performed. What CPT and ICD code are reported for the surgery? What has happened is, there is a hyperparathyroidism, and then after the nuclear medicine they have decided to take down one parathyroid gland. Okay, so let us see what's the code. So if you see, the codes are 500 parathyroidectomy or exploration of the parathyroid, re-exploration with a mediastinal exploration, sternal split or transthoracic approach. So definitely this hasn't happened, because there is no mediastinal exploration that has happened. What happened is, in between these two. And was there a re-exploration? No, they are exploring this parathyroid gland for the first time, because they have seen that the patient is having hyperparathyroidism. So let us tell me what's the answer. So yes, the answer will be 60500, and that is a parathyroidectomy, and E21.3 is the primary hyperparathyroidism. We will not put the modifier 50 here because it is a one disease parathyroid, so that has been removed from one side, and there is no need to put the modifier 50 here. Now, the next important topic is a burr hole. I would always recommend it to have some knowledge about that surgery so that you can visualize better and you can answer better. Now, what is a burr hole? Burr hole is a small hole created in the skull using a drill, typically to relieve the pressure or the drain the fluid. And trephination, which is nothing but trephination is also a surgical procedure where the circular piece of bone is removed from the skull. So the only difference between these two is the burr hole, the hole is very small and you are not removing anything. You are just drilling the hole into the skull, and then trephination is removing the circular piece of the bone. Okay, and the entry point is used to treat the condition like subdural hematoma, or to allow the access to the other procedures such as insertion or insertion of an external ventricular drain, including treating the headache, epilepsy, or even some mental illnesses. Then so that's the reason why we do the burr hole ultrafiltration. And now let us look at the CPT. So let us look at the codes for the burr hole ultrafine. So if you see the code language use burr hole ultrafine. So there is no distinction between whether the burr hole codes are different or ultrafine codes are different. Both you can use the same code for both. What is defined the code is basically after doing the burr hole, what have you done? Have you used the burr hole for the biopsy, or have you used the burr hole for the drainage of the hematoma, or have you used the burr hole for the insertion of the pump, or have you used the hematoma for the aspiration of the cyst? That is very, very important. And then if you look at the code 61250, it is for the supratentorial uh, exploratory, not followed by other surgery. So this is a burr hole where we do the exploration. And here there is an important note that for the bilateral procedure, we need to put a modifier 50, and then there is this burr hole trephine with infratentorial, unilateral or bilateral. Now for this particular code, there is no need to write the modifier 50 because the language of the code includes unilateral or bilateral. Now there is a one very important guideline, which is, you will see it here, that if the burr hole ultrafine is followed by the craniotomy and operative session, then we will code only the craniotomy or craniectomy. That means the burr hole or the trephine is included in that. We will not code them separately. So you begin with burr hole but decided to go for the craniectomy or a craniotomy, then I will code only for the craniotomy. This is a very important guideline one must know. So let us look at what is craniectomy and craniotomy. So first, let us understand the two terminologies. The craniotomy is the bone flap that is removed and replaced after the surgery, while craniectomy, that means a removal. So here the bone flap is removed but not replaced after the surgery. That is the only distinction between a craniotomy and craniectomy. Now, as far as the CPT is concerned, you will see this code for the craniectomy and craniotomy under the code range 61304 and 61576. Now, many of this code under this subheading include the terms craniotomy and ectomy, and whichever procedure is indicated in the documentation, it doesn't matter as both the procedures are covered by the same code. Because if you see all this code, they talk about craniectomy or craniotomy. So what define the code is whether it is a supratentorial, whether it is a infratentorial, and what have you done, whether hematoma, where is the hematoma, that decides your code. Now let us take some example. Baby Smith was diagnosed with meningitis. His physician placed a needle through the fontanelle at the suture line to obtain the spinal fluid sample on Monday. The needle was withdrawn and the area bandaged. A baby required another subdural tab bilaterally on Wednesday. How would you report Wednesday's service? Now here we are talking about the subdural tab. Subdural tapping is basically taking out some part of the cerebrospinal fluid for checking because the baby has got meningitis. Now here the important consideration is the baby has done the procedure on Monday and she has been doing another subdural tap bilaterally on Wednesday, and we are supposed to they told us to code for today's service, that is Wednesday's service. So we will have to code it accordingly. Now if you see the code, it is a 6100. It is a subdural trap through the fontanelle or suture infant unilateral or bilateral. 61001 is a subsequent tap, and 61070 is a puncture of the shunt tubing. So definitely there is a tap, no shunt. So definitely we can eliminate the option C. Now in between A, B and D. Now if you see the option B, it talks about the initial tap and then the subsequent tap. But remember, they told you to code only for the today's service. That is very, very important. So, yes, the A is the correct answer because we have to code only for the subsequent tap. Okay, and subsequent because she already had one tap and we have to code only for the subsequent tap. And if you see, this is the code where the unilateral or bilateral, this wording is also included because this is the indented code. So I'll be reading the code subdural tap through the fontanelle or a suture infant unilateral or bilateral subsequent tap. So since the language of the code includes a unilateral or bilateral, there is no need to write the modifier 50, and that's why A is the correct answer. Now the next question, a craniectomy is being performed on a patient who has a Chiari malformation. Once the posterior inferior scalp was removed, a C1 and partial C2 laminectomy was then performed. The right cerebral tonsil was dissected free of dorsal medulla, and gush of cerebrospinal fluid gave a good decompression of the posterior fossa content. Which CPT code should be used? So what has happened here? The craniectomy. And what are the code given? 61322, 343, 345 and 458. So let us see. This is a craniectomy or craniotomy, decompressive with or without duroplasty for the treatment of the intracranial hypertension without evacuation of the associated intraparenchymal hematoma. 343 is a craniectomy suboccipital with a cervical laminectomy for the decompression of the medulla and spinal cord with or without dural graft. And here they have mentioned Arnold Chiari's malformation. So, and that's what it has been written. Of course, that is one of the clue. But the another thing is there is a cervical laminectomy that has happened. And here what they have seen is they have removed the C1 and partial C2 laminectomy has been done. So after reading all the code language, I can very well say that I can very well tell you the answer. So yes, 61343 is the correct answer. C is the right answer. The next question is, with which code set or individual code can add-on code 61781 be correctly reported? And we have the option. Now here, the important thing is we need to read the parenthetical note. Do not report 61781 in conjunction with 61720 to 61791. That is our first option. Second is 62201 or 77432. So we have the code this, we have the code this, and these codes are also there. So you know what's the answer. So the question like this will tell you how the parenthetical notes are important, and they are just testing your knowledge whether you are reading the parenthetical note properly or correctly, because here they have clearly mentioned we cannot write this code along with all these codes, and all these codes are what they have given as a ABC option. So D is the correct answer. A 6 months old patient require a bilateral subdural trap through the suture. How would this initial procedure be reported? Kindly pay attention to the language of the code and tell me the answer. So yes, the A is the correct answer. B is not the correct because it is talking about subsequent tap. This is the initial tap only. C is not the correct answer because when the code language include unilateral and bilateral, there is no need to write the modifier 50, and so we will go with the answer A. So let us look at the next question. A physician perform a craniotomy on the patient with a severe head trauma and intracerebral hematoma. Due to the patient condition, the procedure was extremely difficult, requiring a significant amount of extra time and effort. What is the correct code for this procedure? So if you see the code, there are only two codes. What is this 313? It talks about intracerebral, and 315 talks about intracerebellar. Okay, there is a slight difference in the the spelling. Now the second important, so definitely it is a intracerebral, and we know that there is a extra time is required, and for that which modifier do we use? That will decide our answer. So yes, modifier 22 defined the additional time, and that's why C is the correct answer. 61313 is the intracerebral craniotomy for evacuation of the hematoma supratentorial intracerebral. Okay, so that will be our answer. So following a motor vehicle collision, a 20-year-old male was given a CT scan of the brain, which indicates an infratentorial hematoma in the cerebellum. The patient was taken into the OR where the neurosurgeon, using the CT coordinates, inside the scalp and drill a burr hole into the cranium above the hematoma. Under direct visualization, he then evacuates the hematoma using suction and irrigates with NS. Hemorrhaging was controlled and dura was closed. The skull piece was then placed back into the drill hole and screwed into the place. The scalp was then closed and the patient was sent to recovery. Now here there are three important things. First is the infratentorial hematoma in the cerebellum. Second important thing is they started with a burr hole, but here there is an important sentence that the skull piece was then placed back into the drill hole and screwed into the place. That means this is a case of craniotomy. Okay, because they must have started with a burr hole, but then when they realized that they require a better visualization and the wider window to access that, they have increased that, they have taken the piece of that skull, then they have treated the patient and they have replaced back. So that is a craniotomy that has happened. Now let us see what are the codes. So we have all this code. You need to read all the code, that what is the kind of hematoma, and then we will see what's the answer. So 61154, it is a burr hole with evacuation and drainage of the hematoma, extradural and subdural. What is the our hematoma? It is the infratentorial hematoma in the cerebellum. 61253 is the burr hole of ultrafine intratentorial, unilateral or bilateral. What has happened in this patient is they started with a burr hole, but then there is a mention that the skull piece was then placed. That means the craniotomy has happened. And if the burr hole and the craniotomy that happened on the same place in the same session, then we code only for the craniotomy. So we cannot even use 61253 along with 61315. Now the 61315, it is the code where we say the craniotomy for the evacuation of the hematoma infratentorial intracerebral, because it is in the cerebellum. And even this is not the correct answer, because again this is talking about burr hole as well as the craniotomy, and we write only one code, craniotomy. Okay, because that's a more severe and more prolonged the procedure. So this is where I end the part 1 and will begin with the part 2 later.